Hello, good afternoon.
हेलो हेलो मैडम.
Hello.
हाँ
Hello, hello.
हॅलो. धरणे मॅडम.
हो बोला ना.
ओके ओके. नाही, मी डॉक्टर माया कराळे.
ओके.
हा, या बाकी जॉईन व्हायच्या आहेत वाटतं ना अजून.
कापसे मॅडम झाल्या जॉईन. स्पीकर
अच्छा.
झाले जॉईन.
ओके.
चालेल.
आपण शार्प 4ला सुरू करायचं ना मग, की थांबायचं 5-10
काहीच
मिनिटं.
नाही करू म्हणजे माझ्याकडून काहीच ऑप्शन नाही. माझ्याकडून काही
अच्छा.
ऑब्जेक्शन नाही.
माया
जगदाळे मॅडम वगैरे या.
हा येस
हा हॅलो
मॅडम सुरू करून घ्या, कारण आपण 3:50 ला सुरू करणारच आहोत. दोन्ही स्पीकर आणि
ओके.
आपले चेअरपर्सन दोन्ही अवेलेबल आहेत. आता आलेत, ऑलरेडी जॉईन झालेत. वेलकम देम आणि स्टार्ट करा.
करू मॅडम मग.
येस.
ओके मॅडम, थँक्यू. नमस्कार, सुस्वागतम सुस्वागतम सुस्वागतम. आज के वेबिनार से जुड़े तमाम आयुर्वेद तज्ञ का हार्दिक स्वागत. नीमा वुमेन्स फोरम महाराष्ट्र राज्य की ओर से इस एनोरेक्टल डिसऑर्डर वेबिनार में आप सभी का हार्दिक स्वागत करती हूँ. आज 20th लेक्चर सीरीज में आप सभी उपस्थित मान्यवरों और मेरे सहपाठियों का स्वागत है. मैं डॉक्टर माया कराळे, अकोला वुमेन्स फोरम की पूर्व अध्यक्षा हूँ. नीमा अमृत महोत्सव कमेटी की कार्यकारी सदस्य हूँ. नीमा वुमेन्स फोरम जैसी सफल संगठना का बीज जहां बोया गया, ऐसी आधारभूत संगठना अकोला नीमा वुमेन्स फोरम की मैं फाउंडर मेंबर हूँ. नीमा अमृत महोत्सव वर्ष की उपलक्ष्य में आज 23 जून से एनोरेक्सिया डिसऑर्डर पर वेबिनार सीरीज नीमा वुमेन्स फोरम महाराष्ट्र स्टेट में आयोजित की है. उसके लिए मैं एक नीमा वुमेन्स फोरम के लिए मैं कुछ कहना चाहती हूँ. ना थकी ना हिम्मत हारी, ना थकी ना हिम्मत हारी, जज्बा है परिवर्तन किसी है सफर जारी. आज की बदलती जीवनशैली से सबके आकांक्ष परिवर्तन आए. सबका की वजह से प्रॉपर टाइम खाना देना, आज खाना, आज प्रॉपर भोजन करना, इन सब चीजों का डाइजेशन का इफेक्ट हो रहा है. उसके कारण एनोरेक्सिया डिसऑर्डर पाए जा रहे हैं. रूटीन प्रैक्टिस में इसके पेशेंट ज्यादा दिखते हैं और आयुर्वेद शास्त्र में एनोरेक्सिया डिसऑर्डर पर परिणामकारक
सदस्य कार्यक्षेत्रातील जन आरोग्य समितीचे अध्यक्ष, सहअध्यक्ष हे तालुका आरोग्य अधिकारी असणार आहे. सदस्य सचिव अंतर्गत आरोग्यवर्धिनी प्राथमिक आरोग्य केंद्राचे वैद्यकीय अधिकारी किंवा प्रभारी वैद्यकीय अधिकारी ही सदस्य सचिव असणार आहे. वैद्यकीय सदस्यांनी निवड कार्यक्षेत्रातील पंचायत समिती सर्व सदस्य ही सदस्य असणार. प्राथमिक आरोग्य केंद्राचे इतर वैद्यकीय अधिकारी, आयुष वैद्यकीय अधिकारी
नीमा वुमेन्स सेंट्रल के अध्यक्ष डॉक्टर मॅडम.
एक्सक्यूज मी माया मॅडम. हॅलो
मॅडम आवाज येतो
मॅडम तुमच्या. हॅलो मॅडम, एक मिनिट. तुमचे मोबाईल आणि 2 मोबाईल चालू आहेत का? तुमचा आवाज एको होतोय ना, त्यामुळे एक कुठला तर डिव्हाइस बंद करा मॅडम. आवाज नीट येत नाही तुमचा.
हॅलो.
ओके, हा आवाज नीट येत नाही. एक डिव्हाइस फक्त बंद करा.
मॅडम
आता नीट येतोय, पण 2 पैकी एकच चालू ठेवा, एक बंद करा मॅडम.
हॅलो.
हा आता ठीक आहे. ओके
बोला. नीमा महाराष्ट्र स्टेट प्रेसिडेंट डॉक्टर जाधव सर, सेक्रेटरी डॉक्टर बाजारी सर, ट्रेजरर डॉक्टर वाणी सर, इनका मैं शब्द सुमन से स्वागत करती हूँ. हमारे महाराष्ट्र स्टेट वुमेन्स फोरम के प्रेसिडेंट डॉक्टर सपना जगदाळे मैडम, सेक्रेटरी डॉक्टर राजेश शिरपरकर मैडम, ट्रेजरर डॉक्टर पार्वती राणी मैडम, आप सभी लोगों का इस वेबिनार में स्वागत करते हुए अत्यंत हर्ष हो रहा है. NIMA State Student Forum Office Bearer members, NIMA Amrut Mahotsav respected committee members, all NIMA State Women's Forum State Committee members, dignitaries, इन सभी का बहुत बहुत स्वागत। आप सब सहपाठियों की उपस्थिति में मैं स्वयं को गौरवान्वित महसूस कर रही हूँ। पुनश्च एक बार आप सभी महानुभावों का स्वागत। टेक्निकल टीम को मैं धन्वंतरी सवन के लिए अनुरोध करती हूँ। पार्वती मैडम, हेलो, सारिका मैडम,
जस्ट अ मिनिट मॅडम, डागा सर
चालू कर।
हाँ
ओके। धन्यवाद सारिका मैडम, धन्यवाद पार्वती मैडम। आज मैं आज के प्रमुख वक्ता और अध्यक्ष का परिचय देने जा रही हूँ। स्वीकार आमंत्रण किया, रखा हमारा मान, स्वीकार आमंत्रण किया, रखा हमारा मान, कैसे करे कृतज्ञता, स्वागत है श्रीमान, कैसे करे कृतज्ञता, स्वागत है श्रीमान। आज की अध्यक्षा डॉक्टर विद्या धरणे मैडम। शी इज वर्किंग विथ Dr. G.D. Paul Foundation, YMT Ayurvedic Medical College, Kharghar, as Associate Professor, Department of Surgery since 2002, and founder of Center of Excellence for Piles, Fissure, Fistula, Laser Therapy, located in Dombivli, Kametu, and Seawoods. Also achieved Limca Books of Record as a surgical team for performing 290 pile surgery in 12 hours on 20 November 2011, that is World Piles Day.
published many research articles in national, international journals. Expert in modified Charsutra treatment in complex fistula in anus. PG and PhD scholar guide affiliated with Maharashtra University of Health Science, Nashik. She has been awarded Stri Kartutva Sanman in 2022. Vice President of Ayurvedic Proctology Association and conducted surgical camps all over India. ऐसे महानुभाव अध्यक्षता हमें प्राप्त हुए हैं। आज के स्पीकर हैं डॉक्टर प्रज्ञा राजेश कापसे मैडम। She is PhD scholar, MS Ayurveda in Operative Wound General Surgery from Government College Usmanabad, BMS from R.A. Poddar Medical College, Diploma in Cosmetic Acupressure, Diploma in Sanskrit, Diploma in Nutrition and Health Education, MA Psychology. She has done some courses like Ayurvedic Massage Therapy, Basic course in Colonoscopy, Certified course Yoga Techniques, Meditation and Sujok also. She has worked with various television channels like Sam Marathi, DD Sahyadri, ABP Maza as expert on surgical health problem. She has worked with All India Radio Medical Education, Arogyam Dhana Sampada, Hello Doctor. Invited as a speaker, various national, international seminar, executive committee members of Ayurved Vyaspeeth. International experience participated in World Congress on Ayurveda at Pondicherry, Kolkata, Gujarat, World Ayush Expo, article published in Ayurveda journals in following topics like constipation, obesity, arthritis, diet, and anorectal diseases. She has been awarded Himalayan Ayurveda Award, Sir J. Tata Scholarship winner, Kamal Bhushan Award by Ayush Maharashtra State, Dr. ABPJ Abdul Kalam Award, Young Ayurveda Practitioner Award. ऐसे बहुआयामी व्यक्तित्व के धनी अपने विषय में पारंगत अनमोल मार्गदर्शन करेंगे। मैं डॉक्टर माननीय प्रज्ञा कापसे मैडम से आमंत्रित करती हूँ कि आज के प्रमुख विषय पर अपना व्याख्यान स्टार्ट करेंगे।
Hello, namaste. Can you hear me?
Yes, ma'am.
Yeah. Will someone allow me to share the screen, please? Because it is turning only the host can share in this meeting. Hello?
Daga madam?
I am not able to share the screen, madam.
Yes, Daga madam.
Yes, ma'am. बोला.
मॅडम शेअर करू शकत नाही स्क्रीन. प्रज्ञा कापसे मॅडम शेअर करू शकत नाहीये प्लीज.
Just make me the co-host so that I can
share screen. Share screen पर बघा ना मला.
No, it is coming only the host can share the screen.
I'm खाली icon आहे share screen चा.
Yes, I am clicking on that, madam. It is coming. Just make me co-host.
Okay. Actually co-host बनवता येत नाही आहे. काहीतरी
Without that, I cannot share my screen.
Okay, ma'am. I'll try. Just wait. Just a minute.
You can just click on my name, madam, and just click make co-host.
हेलो
Yes.
मैडम शेयर किसको करना है? मैं होस्ट बना देता हूँ उनको।
Prajna Kapse, myself.
प्रज्ञा मैडम को करूँ होस्ट?
प्रज्ञा कापसे सर. प्रज्ञा कापसे.
ओके ओके. हाँ मैडम, होस्ट किया वो बना सकते हैं, अब अपना स्क्रीन शेयर कर सकेंगे. प्लीज प्लीज.
Yes.
आपसे मैडम,
Yes. I
नाउ यू कैन शेयर द स्क्रीन.
Yes, yes, sir. Yes. Is it visible now?
Yes, ma'am. Yes.
A very good afternoon to all of you. And I would like to give my special thanks to NIMA Women's Forum, Maharashtra State, for giving me this opportunity to share my views on the topic which has been assigned to me today, anatomy and physiology of anal canal and general anorectal examination. Basically, I was told that this lecture will be for general practitioners. So I will not go in too much details, but making it brief to introduce you regarding the anatomy and physiology of anal canal. I am working with Podar Medical College, Worli, Mumbai as an assistant professor. Also, I am a SIFA member. SIFA is Shiv International Fraternity of Ayurveda based in Singapore. There we are having a big vision to propagate Ayurveda worldwide. And we are currently working with Sharsutra courses there. So we have designed these courses, and the basic introductory topic and the introduction starts with the anatomy and physiology of anal canal. So someone is not muted. Can you see, madam, please mute the mic. Yeah. So all of us, we know that anal canal, when we see or when we learn regarding the anatomy of rectum and anal canal, these two entities are closely associated with one another. The Latin word rectum intestinum means it is a straight intestine. So it is the last part of large intestine and connects sigmoid colon to anal canal. It begins at S2, S3 level and ends at perineum of about 12 to 16 centimeter in length. So this is how the rectum and anus are situated in the diagram. So it ends in an expanded section which is called an ampulla. It stores the feces means stool or fecal matter, before it released via anal canal. Morphologically similar to the rest of large intestine, but it doesn't have tinea, hostra, or appendicitis, epiploicae, and semilunar folds. It is having two flexures, sacral flexure and perineal flexure. So sacral flexure is having concavity of sacrum, and perineal flexure is having an encirclement of rectum by levator ani, which we can feel at the time of examination. Now there are three rectal folds as well. Hello. The slides
Yes,
are
madam.
visible.
आता दिसत नाहीत मॅम.
Now is it visible?
Not still, ma'am.
I will have to again share. Is it visible now?
Yes, ma'am. Yes.
Yeah. So it is having three rectal folds: superior fold, middle fold, and inferior fold. So superior rectal fold is intraperitoneal in position, middle rectal fold in retroperitoneal in position, and inferior rectal fold is under pelvic diaphragm, which is extraperitoneal in origin. Now see, this is a basic diagram which you can see. There all the minute structures have been designated and named according to their anatomical position. Now sigmoid colon is the uppermost part, which in turn progresses forward in rectum, ending
हॅलो
in anus.
मॅम
Hello?
सॉरी टू मॅम सॉरी पण बाकीचा आवाज खूप येतोय.
हा, म्हणून सगळे माईक प्लीज म्यूट कराल का? Is it okay now?
नो मॅम स्टिल व्हॉइस इज देअर.
Because there is no disturbance in my side.
नाही मॅडम, तुमचा आवाजच हळू येतोय.
नाही, माझा आवाज आता बरोबर येतोय का?
हा,
Yes,
आता
yes,
येतोय
yes.
मॅडम,
Yes,
आता
yes.
येतोय.
ओके ओके.
सगळ्यांना वाटतंय की
So
सगळ्यांनी
sigmoid colon in turn progresses forward in rectum, which ends in anus, which is the last part of the intestine. So it is covered with the peritoneum. You can see there are the folds, there are ampulla which are seen here, and you can see the layer corpus cavernosum, that reddish layer outside the rectum. Anal crypts are seen. Then sphincter of ani, internal sphincter and external sphincter, both can be marked here in this diagram. Pectinate line, dentate line, and the red big muscle which is seen, which is long in length, it is called levator ani and puborectalis. So this is how the rectum and anal canal, they are situated. Now basically, if we see for blood supply, upper 2/3 part of the rectum and or anal canal is supplied with superior rectal artery, and lower 1/3 part with middle and inferior rectal artery. Venous drainage is associated with superior rectal vein and middle rectal vein, and lymphatic drainage with pararectal, inferior mesenteric and internal iliac lymph nodes. Nerve supply is sympathetic with L1, L3 and parasympathetic from S2 to S4. Hypogastric plexus and pelvic. Hello?
प्रज्ञा मॅम, सॉरी टू डिस्टर्ब यू. मॅम, तुम्ही डॉक्टर गिरीश दादाला को-होस्ट करता का? कारण खूप लोकांचे माईक चालू आहेत, त्यांना म्यूट करता येत नाहीये, कारण मी को-होस्ट नाहीये त्यांना. मला को-होस्ट
गिरीश डागांचा माईक म्यूट करायचा आहे का?
नाही नाही, तुम्ही फक्त को-होस्ट करा डॉक्टर डागांना.
ओके ओके, जस्ट अ मिनिट. Actually, there is an option just make host, no option of co-host here.
ऍक्च्युली काय झालंय की को-होस्ट खूप डिस्टर्बन्स आहेत. सगळ्यांना रिक्वेस्ट आहे की सगळ्यांनी आपले आपले माईक म्यूट करा, कारण आवाज येतोय सगळ्यांकडनं. ओके प्रज्ञा मॅम, आता सगळ्यांनी स्वतःला म्यूट केलं. यू कॅन कंटिन्यू.
हा, कॅन आय स्टार्ट? Now the slides are visible.
Yes, ma'am.
Okay. So now this is coming to the anal canal. Now it is closely associated with external sphincter and internal sphincter. So external sphincter is very, very important. It is voluntary in nature and internal sphincter is involuntary in nature. So anal canal is located below the pelvic diaphragm. It is approximately 4 centimeter long and it is directed downwards and backwards. Now there is a transitional zone called anorectal junction, which is squamo-columnar junction. Dentate line, as I have told you, we have seen in the diagram previously, it divides upper 2/3 and lower 1/3 of anal canal, which is formed by anal column of Morgagni, which consist of anal sinuses. And these sinuses, they drain the anal gland. There is white line of Hilton, which is anocutaneous line, intersphincteric groove, which is slightly below the pectinate line. And there are two sphincters, internal and external, which are very, very important in the aspect of examining the patient and diagnosing and treating as well. See, these are the anal columns, orange in color. In between, the sinuses are situated, which drain the anal gland. So pectinate line or Hilton's white line is also there. The zone of pecten has been shown in the diagram and surrounded at the end with mucocutaneous junction and skin. So this is how the crypts are visible and the anal glands are situated inside the anal crypt. Now anal canal is having a blood supply with superior rectal artery and inferior rectal artery, venous drainage with superior and inferior rectal vein, and lymphatic drainage with superficial inguinal lymph nodes and internal iliac lymph nodes. This is how the sagittal view of anorectal area it looks like. Basically, the angle at the time of excision is very important. If that angle is maintained, there will be no problem arising like constipation and later on resulting in piles, fissure or fistula. So puborectalis muscle, the tone of that muscle, which engulfs the external anal sphincter and internal anal sphincter, maintaining the angle of anorectal area is very, very important. कोणाचा तरी माईक अनम्यूट आहे, प्लीज म्यूट कराल का?
विद्याजी.
So ischioanal fossa and anal triangle, these are the most important structures on each side of the anal canal. In this diagram, you can see there is a perianal space as well, which surrounds the anal canal below the white line. And these fossae, they are important when we diagnose the patients, especially of anorectal abscesses. So these are the anorectal relations in female, where it is surrounded with ovary, fallopian tube, then uterus, bladder, and vagina. So these are the diagrammatic presentation with all these structures. In male, it is surrounded with the prostate gland, then ureter, urinary bladder, ductus deferens, and on the both sides there are seminal vesicles with ejaculatory duct. Now there are two types of nerve supply, intrinsic nerve supply and extrinsic nerve supply. So intrinsic nerve supply, it is present within the wall of gastrointestinal tract from esophagus to anus, and extrinsic nerve supply is arising from autonomous nervous system. See, there is Orbach plexus or myenteric plexus, which we say. It regulates the movement of gastrointestinal tract. So inner circular and longitudinal muscle is very, very important, which maintains the tone of this myenteric plexus. And Meissner plexus is the second one, or submucosal plexus, which regulates the secretory function of gastrointestinal tract. It is within this muscular and submucosal layer. See, this is the Orbach's plexus. This diagram is showing, and Meissner's plexus. In between serosa, longitudinal muscle, circular muscle, submucosa, and mucosa. Now, this is again the diagram which shows the glands in mucosa, submucosal plexus, how it is situated, the artery, the nerve, the myenteric plexus, along with the serosa or areolar connective tissue and epithelium. So this is how we get the picture. Now, enteric nervous system, it contains myenteric plexus, submucosal plexus. Now, myenteric plexus, it is closely associated with the motor neuron, where the longitudinal and circular smooth muscle layers of the muscularis, they are regulated. Whereas the interneuron layer in between the myenteric plexus and submucosal plexus and mucosal epithelium, it is regulated with the help of motor neuron and interneuron. Sensory neuron, they also play a very important role in the process of defecation or normal physiology of rectum. So this is how sympathetic and parasympathetic nervous system, they play a very important role. Sympathetic arises from thoracic and lumbar segments of spinal cord, that is of the level T5 to L2. Ganglia, celiac and mesenteric inhibit movement and decreases the secretions, constriction of sphincter is also regulated with this. And parasympathetic is related with the cranial nerve and sacral nerves of S2, S3 and S4, accelerates the movement and increases the secretion. This is how the nerve supply with celiac ganglion, superior mesenteric ganglion, and this is how the impulses are passed off. Now coming to the physiology, rectum serves as a reservoir of fecal content. I'll just mute. Many people are making noise. Yeah. So basically, rectum serves as a reservoir of fecal content, and anal canal, it regulates the continence and defecation. So when we see that the person is having constipation or a problem in defecation, we have to think again and again regarding the normal physiology of the anal canal. Please mute your mic. Then coming to the defecation reflex. See, there are 3 levels of action basically related with the defecation reflex. One is at intrinsic level, one is at the level of spinal cord, and the last one is having an involvement of higher center. So intrinsic level, it is associated with myenteric defecation reflex. Spinal cord level associated with parasympathetic defecation reflex, and third one is with higher central involvement. It starts when the rectal pressure increases to around 18 mm of Hg. रेक्टल प्रेशर जब बढ़ता है तब डेफिकेशन का रिफ्लेक्स आता है. at 55 mm of Hg pressure, expulsion of fecal matter occurs. Now, intrinsic defecation reflex, it is a very weak reflux. It cooperates with the stimuli with distension of rectal wall by entry of feces. It has the receptors which are the stretch receptors in the wall of rectum. Sensory fibers are there which are afferent in nature, terminating in myenteric plexus. So basically center is at myenteric plexus, and motor signals with efferent reflux to the smooth muscles is initiated with the result of contraction of smooth muscles of rectum and sigmoid colon, which regulates the relaxation of internal sphincter. Now coming to the parasympathetic defecation reflex, the stimuli, there is distension of rectal wall by entry of feces. There are stretch receptors in the wall of rectum. Parasympathetic nerves are there in afferent role. This basic center is spinal cord S2, S3, S4 level. Pelvic parasympathetic nerves are efferent in nature, and overall effect is in contraction of smooth muscles of rectum. Means rectum के जो smooth muscles है वो contract हो जाते हैं, and sigmoid colon, and relaxation of internal sphincter afterwards. So this is how the sensory nerve fibers are there, and impulses from cortex towards the anal sphincter is passed on with the help of voluntary motor nerve and involuntary motor nerve. Involuntary means parasympathetic division. Now, this is overall the anatomy and physiology of anal canal. Now, coming to the general examination in anorectal condition, when basically we examine the patients when they come to our OPD, each and every patient will tell you कि मुझे बवासीर की तकलीफ है, मुझे पाइल्स की बीमारी है, ऐसे हर एक पेशेंट आपको कहेगा, because no one is educated with the special entities like fissure, abscess, rectal polyps, fistula and all that. So ourselves, we have to diagnose and treat them according to the diagnosis or according to the examination and the findings which we get. So basically, what are the indications for the examination of anorectal condition? So these are the indications: bleeding per rectum, mass per rectum, when there is a pain at anal canal at the time of defecation, when the patient is having constipation, when the patient is having discharge or prolapse of rectum, and pruritus ani, means there is excess itching. So these are the indications with which the patient may come to your OPD, and we have to examine them properly inside our clinic. So basically, when we explain the procedures and ask for the consent, when patient will come to your OPD, you will have to convince him. You will have to tell him in detail what is the anorectal examination, for what you are procuring that particular procedure, for what purpose you need to make the patient lie down in the lithotomy position or left lateral position, whatever position you will give to the patient. So all these minute details you will have to explain, because this is very, very important with the what we can say, which is closely related with the medico-legal aspect. And basic small things that we have to remember, such as when female patient is there in our OPD, always we have to make the female staff nurse or any female candidate or female doctor or compounder or whatever besides the patient. Or when male patient is there, we have to make male candidate stand over there, because patient should feel very safe when doctor will examine him or her. Before that, डायरेक्टली पेशेंट आया और हमने बोला कि चलो सो जाओ, ऐसे किया तो यू विल नॉट हैव अ कंप्लीट ट्रस्ट. सो पेशेंट के ऊपर अगर आपका प्रभाव पड़ना है तो पहले उसका विश्वास जीतना सीखो. जस्ट कन्विंस हिम फुल्ली दैट हाउ यू आर गोइंग टू एग्जामिन. Take a proper consent. Rather, I would like to suggest you all, if you are running general OPD, just make, जैसे आप मेडिकल सर्टिफिकेट का एक नोटपैड बना के रखते हैं, वैसे कंसेंट का नोटपैड बना के रखिए कि छोटे मोटे एग्जामिनेशंस के लिए आप हर एक इस पे पेपर पे, कंसेंट पेपर पे पेशेंट की साइन ले सकते हैं. एंड इफ विटनेस इज देयर और पेशेंट्स रिलेटिव इज देयर, you can take his or her sign as well. So these are the procedures which we have to explain at the time of consent. जैसे आयुर्वेद में भी बोला है, सुश्रुत ने उस वक्त बोला है कि अश्मरी चिकित्सा अध्याय में अक्रियायाम ध्रुवो मृत्यु क्रियायाम साधुकारिणा तस्मात् आपृच्छ कर्तव्यम. अक्रियायाम ध्रुवो मृत्यु क्रियायाम संशयो भवेत् तस्मात् आपृच्छ कर्तव्यम क्रियायाम साधुकारिणा. मतलब आप पूछो हर एक पेशेंट को करते वक्त, अगर किया तो भी प्रॉब्लम है, नहीं किया तो भी प्रॉब्लम है, मृत्यु अटल है या संभव है, संशय है, अगर थोड़ा भी आपके मन में संदिग्धता है तो उसके पहले पेशेंट से हर एक कर्म करते वक्त पूछो, कंसेंट ले लो और उसके बाद ही वो क्रिया करो एंड गो फॉर दैट प्रोसीजर. So basically these are the procedures: inspection, palpation, digital examination and proctoscopy, which we perform normally in our OPD. Now there are certain other different procedures, लेकिन आज का जो बेसिक सब्जेक्ट है उसके लिए हमने जो जनरल प्रैक्टिशनर्स के लिए जो बताना है, तो these 4 procedures, if you will get mastery on these 4 procedures, तो आपको एटलीस्ट इस जगह पे कहाँ पे ये प्रॉपर पेशेंट रेफर करना है, इतना भी समझ में आ गया ये लेक्चर सीरीज अटेंड करने के बाद, तो भी बहुत कुछ हमने हासिल किया, ऐसे मैं बोल सकती हूँ. Now the position which we give or which we have to give to the patient is left lateral position and Sims position or lithotomy position, dorsal position, knee elbow position or right lateral position. So see, these are the certain positions. Now the position which is there in the right upper corner is left lateral position. Here in this position, when you will tell patient to lie down in this position, just cover the private part with some cloth to make sure or to secure the safety assurity to that patient, specifically if she is female. And lithotomy position, all of you know how to be given. So this is the clockwise position, how we describe the entities inside the anal canal. So anteriorly it is 12 o'clock, posteriorly it is 6 o'clock, left side it is 3 o'clock and right side of the patient is 9 o'clock. So this is how we describe the positions.
there is external examination called inspection. Now, what we inspect or what we diagnose or what we can see or assess in this procedure or in this process, if the patient is having any type of skin disease, fungal infection or small eruptions, heat boils, so we can just see, inspect that particular part and diagnose it. Skin tags also we can diagnose with the help of inspection. So keen observation and making your eyes open always is very, very important in anorectal examination. Genital wart, anal fissure, anal fistula, external hemorrhoid, rectal prolapse, piloneedle sinus, external thrombosed pile. All these entities are important, which we just diagnose and treat also if we are rightly inspected the patient. We have rightly inspected the patient. Now, palpation of perineal region, perianal region is always important, because if there is a ischiorectal abscess, then we may feel fluctuation or induration or tenderness on that particular swelling in that area. Or any fistula external opening is there, we can just feel with the help of finger when we palpate that particular area, and we can come to a diagnosis that patient is having fistula in ano, along with the depth and direction of that particular tract with the help of finger. So how that tract is situated, that also can be diagnosed with the palpation. And then lastly, coming to the digital examination. So we can explain what you are going to do, because उंगली डाल के जांच करना है या फिर अंदर से एक मलम लगा के जांच करते हैं, ऐसे इसमें अगर हम लोग बोलेंगे पेशेंट को, तो शी और ही विल बी मोर कम्फर्टेबल. आणि तुम्ही काहीच न सांगता डायरेक्ट जर डिजिटल एक्झामिनेशन केलं तर पेशंट मे स्क्रीम. सो जस्ट डू इट विथ प्रॉपर कंसेंट and proper explanation. Just lubricate your index finger, wear the gloves, of course. Take the xylocaine jelly over the index finger, lubricate it properly, and place pulp of the index finger on the posterior anal verge. Then press gently on anus and slip the tip of index finger to the anal canal. Avoid using force and allow the sphincter to relax. So just wait for 2 to 3 minutes to make sure that the jelly has shown its action properly. Some sort of anesthetic effect is there with the help of xylocaine jelly, with which little bit relaxation of sphincter you will get at the time of examining the patient. Sorry. So if the patient is having fissure in ano, he will not allow you for digital examination. So how will you come to know? When you will spread 2 buttocks and you will see the external anal fissure, means there is a cut. There will be a small cut over the anal verge, mostly on 6 o'clock or 12 o'clock. These are the commonest positions. If the condition of fissure is very acute and bleeding in nature, in that case, you should not go for digital examination, because patient will have severe pain in acute condition. If the condition is chronic, then you may opt this option of digital examination to go further. So just look and confirm first whether the patient is eligible for the digital examination or not. कधी कधी पेरिएनल ऍब्सेस पण असतो, ज्याच्यामध्ये भरपूर टेंडरनेस असतो आणि ऍट दॅट टाइम द पेशंट विल नॉट अलाउ यू फॉर this digital examination or per rectal examination. So this is how you can pass your finger inside the anal canal and diagnose the condition. Then you will have to look for the tone of the sphincter. How the tone of the muscle is, whether it is too tight, whether it is moderate, or whether it is too much relaxed. If it is too much relaxed, then you will have to take proper thorough history, whether he or she is having any history of previous operative procedure. So there she may land up in this problem of loosed or lost tone of the sphincter. Tenderness may be there, for which we have to look for. Thickening of wall, which we have to palpate, because many conditions are there which are or may be malignant in nature, where abnormal feeling with the texture of the mucosa of the anal canal may be there. Then internal opening of fistula, when we do per rectal examination, we can feel the internal opening of fistula, most probably at 6 o'clock, or if the track is radial or straight anteriorly, then maybe around 12 o'clock, 1 o'clock, 2 o'clock, or like that. Most probably at the level of dentate line. So internal opening of fistula can be felt if there are small rectal polyps, anal polyps, or in internal anal wart, or ulcers by absence of normal smoothness. Now this will need an expertise. So when you will gain the experience of examining thousands of patients again and again, just observe normal also, then you will come to know what is abnormal. 100 नॉर्मल पेशंट तपासल्याशिवाय तुम्हाला एक ॲबनॉर्मल पेशंट कळणार नाही कसं आहे. म्हणून काही त्रास नाहीये, बट स्टिल इफ he or she is not having any problem with per rectal digital examination but having some anorectal problem, then you will have to look for. Okay, so anteriorly we have to look for the prostate, seminal vesicles, bladders in male, and vagina, cervix, uterus in female. Also anteriorly we can look for presence of pus, or if blood discharge is there, or any malignant deposit is there, or any type of growth like tumor of sigmoid colon which is extending downward till the anal canal. It may be filled through the pouch. Laterally we can see the abscess which is tender and dense, and posteriorly sacrum and coccyx. Okay, now when you will examine all these conditions, you will have to tell clearly to the patient what type of disease he or she has. So you will have to maintain a good case paper with you. Most probably you can draw good diagram with the clockwise position. Anushri Renuka Shiregond, please mute your mic. So you will have to just tell her or him with a proper drawing of diagram where the position of that particular disease is situated. For example, pile mass is there. Is it situated at 3 o'clock, 7 o'clock? Is it external pile or internal pile? Is it fissure? Is it fistula? Now, how the track is going from external opening to internal opening? Is it curved tract or is it straight tract? So all these entities you can just show by making a simple drawing to the patient, by which the patient will come to know exactly what has happened to him. Laterally, we can feel for ischiorectal abscess, which may be tender and tense, and posteriorly, sacrum and coccyx. Prostate examination is also one of the points when we go for anorectal condition diagnosis. As all of us we know, normal prostate measures approximately 3.5 centimeters and protrudes 1 centimeter into rectum. Can be felt through anterior rectal wall as well when we examine the patient with digital examination. If there is slight tenderness, there may be prostatitis, or we can ask patient for discomfort or urge to urinate, and we can come to the diagnosis, or we can come to the conclusion that he may have benign hyperplasia of prostate. Okay, or it may be a malignant condition as well. So enlargement is smooth and maybe unilateral or bilateral. The gland feels rubbery or slightly boggy. Okay, so cancerous prostate, we may feel a symmetric hard consistency with presence of palpable nodules over that area. So this is how we can examine. So basically all these conditions, their piles, fissure, fistula, we have to diagnose properly after giving the proper position, that is left lateral position. Then just do the inspection with keen observation. Just see whether the patient is having any type of skin problem, fungal infection and all that. And then you can just go further for the digital examination. Palpation is also important. When you will touch the particular part surrounding the anal canal, you will have to look for the tenderness, any type of swelling, especially in abscess. 4 R are there: rubor, dollar, calor and tumor. Tumor means swelling, calor means there is a local temperature which is raised, which we can feel with the back of our hand or palm. Then rubor is redness and dollar is throbbing pain or tenderness is there. So these 4 R are there for abscess, which we can confirmly diagnose with the help of palpation, inspection, and lastly for digital examination. So digital examination, where to do and where not to do. Acute condition मध्ये करायचं नाहीये digital examination. If there is thrombosed piles, external prolapsed piles which is thrombosed and very painful in nature, or gangrenous pile mass is there, in that case the patient will not allow you for doing this digital examination as well. Or even there is a severe infection of anal canal or anal gland where the perianal abscess is there. If it is superficial, the patient will have more tenderness, severe tenderness. In that case also, you cannot continue the digital examination. So all these minute points are very, very important. And if patient is okay with digital examination केल्यानंतर patient ला काही त्रास नाही झाला, then we can opt later on the option of proctoscopy. So in your clinic, you can purchase 3 sizes of proctoscope. One is large size, another is medium size, and third one is pediatric size of proctoscope. If small kid will come to you, then you should have that facility also at your clinic. Okay. So proctoscope is having two parts, obturator and proctoscope sheath. It should be of good quality of pure stainless steel. Just make sure that while examining each and every patient for proctoscopy, you will have to sterilize, wash properly and sterilize that proctoscope before its use. So you can just diagnose these entities, internal piles. So if the internal piles are there at 3 o'clock, 7 o'clock and 11 o'clock position, whether they are first degree internal piles or second degree internal piles or third degree, we can diagnose them with the help of proctoscope. Now proctoscope can be used for diagnosing and treating the entity also. डायग्नोसिस साठी पण उपयोग होतो आणि काही प्रमाणात ट्रीटमेंट साठी सुद्धा त्याचा उपयोग होतो. सो ऍट द टाइम ऑफ सर्जरी, when we take the patient on the table in lithotomy position, at the time of surgery, proctoscope is needed for proper visualization of anal mucosa. After the spinal anesthesia, when the sphincter gets relaxed properly and we can visualize the condition very clearly. So internal piles can be visible with the help of proctoscopy. Then ulcers, if anal ulcers are there, we can use or we can see or we can examine with the help of proctoscope. Whatever length the proctoscope has, we can examine that much part only. So if the pathology is situated above that particular area or beyond that length, then further we will have to refer the patient for sigmoidoscopy. So there is a flexible sigmoidoscope as well. Nowadays, very advanced technology is there, which will cause no harm or pain at the time of examination. So you can go for that also with proper training. Okay. If there are certain growths like anal polyps, which are bleeding polyps in nature, most probably in kids, then in that case, also proctoscope is useful. If the internal opening of fistula is situated, then we can just have a clear view of picture when we illuminate the proctoscope with proper source of light. Now proctoscopes are of different types and sizes. So self-retaining proctoscope is there, slit proctoscope is there, half slit, complete slit proctoscope is there. So many types and many varieties, whatever as per your choice and feasibility, you can purchase them. Okay. So if there is a chronic fissure, in acute fissure, if digital examination is not allowed, you can also not go for proctoscopic examination. If it is chronic, if patient is allowing for rectal digital examination, then only you can opt for the proctoscopy. इसलिए हम लोग स्टूडेंट को बोलते हैं पीआर से प्यार करो. मीन्स व्हाट? PR examination, just train your finger first for examining the patient, and then just confirm with your confidence for that particular matter. You will have to gain perfect knowledge regarding the anatomy, regarding the physiology, regarding the proper position of the diseased entities, and then only you will have to go for the confirmatory diagnosis, and then you will not be mistaking anywhere. Unless and until you are having that much confidence, you will not be able to treat the patient. आणि तेवढा कॉन्फिडन्स तुम्हाला आला तर तुम्ही ऍटलिस्ट तुम्हाला ट्रीटमेंट जरी करता आली नाही तरी सुद्धा तुम्ही प्रॉपर ठिकाणी कन्झर्वेटिव्ह ट्रीटमेंट देऊन त्या पेशंटला प्रॉपर ठिकाणी तुम्ही रेफर करू शकता, एवढं नक्की. बिकॉज मेनी सर्जन्स आर स्पेशालिस्ट इन कॉम्प्लेक्स फिस्टुलाज, मेनी सर्जन्स आर स्पेशालिस्ट इन ओनली पाइल्स or hemorrhoids treatment and various techniques used to treat hemorrhoids. So accordingly you can refer to the concerned surgeon. Okay, then see, these are the hemorrhoids, internal hemorrhoids, and which are positioned according to the superior rectal vein. There are three main branches: 3 o'clock, 7 o'clock, 11 o'clock. These are also visible with the help of proctoscope. These are the 4 grades, clinical grades: first degree, second degree, third degree, and fourth degree. First degree means where there is no prolapse, just prominent blood vessels are there, and when we observe with the help of proctoscope, we can visualize these blood vessels with mild swelling at that area. Second degree, there is a prolapse which emerges with strain but spontaneously reduces and returns back to its position inside the anal canal. Third degree, there is a prolapse which emerges or comes down with straining and needs to be pushed back in with the help of digital maneuver. And in fourth degree, even if we digitally just repositioned it, or we will try to manipulate it or push back it inside the anal canal, it is not going inside. It is just there outside, remaining on its position. That means it is fourth degree internal pile or internal hemorrhoid. So all these entities we can examine in the general anorectal examination. So this is what I would like to conclude my lecture or my talk today. If you are having any query, how to do it, or and videos, how to examine the patient, how to give lithotomy position or left lateral, you can get all these videos on Google if you will search them. The basic entity is proper knowledge of anatomy and physiology and proper diagnosis, confirmatory diagnosis with the help of good examination. Okay, so I hope it is clear to you all. Thank you so much. Again, I would like to give my sincere thanks to the organizers for giving me this opportunity. Thank you.
धन्यवाद डॉक्टर प्रज्ञा काकसे मैडम, आपने अच्छे से एनाटॉमी एंड फिजियोलॉजी ऑफ एनल कैनाल एंड जनरल एग्जामिनेशन ऑफ एनोरेक्टल इस पे बताया, उसके लिए बहुत बहुत, और आप सभी आयुर्वेद तज्ञों को ये समझ में आया होगा, ये इसलिए आप धन्यवाद मैडम।
थैंक यू।
अभी मैं आज की अध्यक्षता डॉक्टर विद्या धन्य मैडम को अध्यक्षीय भाषण के लिए आमंत्रित करती हूँ।
Thank you, madam. Thank you so much. Thank you, Dr. Pradnya Kapse, for a very nice lecture. It was very informative. Once again, thanks NIMA Women's Forum for inviting me and giving me the honor to chair this wonderful session. After such a nice lecture and such a nice elaboration, I would like to focus on only 3 points. There are 3 points I would like to discuss with you all. The first point is the importance of knowledge of anatomy. मैडम ने हर बार बोला है, हर उनकी स्लाइड के बाद बोल रहे हैं कि आपको ये नॉलेज होना चाहिए. Why it is necessary? Because whenever you are dealing with any pathology, you are dealing with any disease of anorectal disorder, you are dealing with the anatomical structure present there. For example, if you are dealing with any piles patient, always keep in mind you are dealing with some kind of plexus over there. You are dealing with anal cushions over there. So whenever you treat any piles patient, always keep in mind you are dealing with plexus and anal cushion present over there. Same thing when you are dealing with any fissure patient, madam has rightly said there is a linear cut over there, and don't forget about the sphincter spasm. So whenever you treat any patient of fissure, always keep in mind you are dealing with any wound. So only wound healing is not important. You should take care of the spasm of internal sphincter. The third, it's very common disease of proctology is fistula. Whenever you deal with fistula patient, always keep in mind there is some infective pathology over there, which is not treated or cured by any antibiotic or any medicine. You need to give a good drainage to this patient via any procedure or Kshara Sutra. But always keep in mind that you are dealing with any infective pathology which needs some intervention. The second important point is, madam rightly said, importance of digital examination. It should be done if you want to do some more practice in proctology. So make an habit to do the PR examination of patient. That will make you more and more competent. Madam has rightly stated, when you complete your 1000 PR, then only you can identify the abnormal PR. So make a habit to your finger to examine the patient. So there are n number of things. She rightly said the tone of the sphincter, anal mucosa, and all internal opening of fistula, everything. So make an habit to examine each and every anorectal patient with digital examination. Third most important thing which I want to tell in this lecture, always after this all thing of anatomy, physiology, and examination, whenever you diagnose any patient, this anorectal patient can be categorized into three. As a practitioner, you should know what are the categories. After diagnosis, these patients are categorized into three categories. First category is a conservative category. This category patient doesn't need any intervention, any surgery or anything. They can be treated only with the medicine and some kind of our Ayurvedic therapies. So you should know the bunch of patients which are made for conservative. For example, first, second degree piles, proctitis patient, acute fissure patient. They are a clear indication for the conservative treatment. Second category is operative patient. These patients are those who need to go for the surgery only. For example, abscess. Any perianal abscess or any fistula is a case of surgery only. You can't treat that patient with some kind of conservative line of treatment. And the last and the third category is a patient who need conservative followed by operative. For example, if you have prolapsed thrombus piles, in that case, you can treat that patient with some kind of medicine and then you can post a patient for OT. So these are the categories that you can learn in your practice. After diagnosis, just categorize your patient into three: conservative, conservative plus operative. Fourth thing I want to tell you on this forum is that as a female practitioner, you should not ignore the female practice practice patterns. In our practice, we get many patients uh, who are willing for pregnancy, or the pregnant females who are who are getting who are getting complaints of piles. So in this your coming session, you should try to learn how to handle this kind of patients, female patient with our therapies. So I think this is more than enough. Most of the things are madam has rightly said. So this is all from my side. Again, thank you, Nima. Thank you for the opportunity given to me.
थैंक यू विद्या मैडम। आज विद्या मैडम ने भी बहुत सरल शब्दों में अपने को अच्छे से समझाया है, इसके लिए आज उनके बहुत बहुत धन्यवाद। अभी किसी को क्वेश्चन आंसर की तरफ जाना है तो आप प्रश्न पूछ सकते हैं, तापसी मैडम और धरनी मैडम आपको रिप्लाई करेगी। हेलो हेलो, किसी को कोई क्वेरी है? हेलो, एनीवन? हेलो हेलो,
आयुर्वेदिक प्रोसिजर्स बद्दल सांगितलं, ट्रीटमेंट बद्दल, तर बरं पडेल पुढच्या कन्झर्वेटिव्ह प्लस
प्रोसिजर्स किंवा कन्झर्वेटिव्ह ट्रीटमेंट आपल्याला पुढचे जे लेक्चर्स आहेत त्यात मॅडम ऐकायला मिळणार आहे, कारण आजचा जो विषय हा फक्त अनाटॉमी, फिजिओलॉजी आणि एक्झामिनेशन।
राईट राईट, सॉरी।
सबको ये आज की एनाटॉमी एंड फिजियोलॉजी मुझे ऐसा लगता समझ में आई होंगी, और किसी को इसके बारे में कुछ प्रॉब्लम होगा, एनी क्वेरी होंगी तो आप पूछ सकते हैं, नहीं तो मैं अपने आखिरी कार्यक्रम के पड़ाव की तरफ जाऊंगी। प्लीज।
और if anyone has query after this program also, they can just contact me or mail me. You can share my WhatsApp number and mail ID also, madam, with all.
ओके, थैंक यू डॉक्टर प्रज्ञा कापसे मैडम एंड डॉक्टर विद्या धरणे मैडम। इनके लिए मैं एक कहना चाहूंगी, हौसला कभी कम नहीं रखा, हौसला कभी कम नहीं रखा, मुश्किलों के तूफानों का किया सामना, मुश्किलों से तूफानों का किया सामना, आज हर तरफ से मिल रही है, आज हर तरफ से मिल रही है सफलता की शुभकामना। आज का कार्यक्रम का आखिरी चरण है आभार प्रदर्शन। क्या मैं कर सकती हूँ कि अभी और किसी को कुछ पूछना है?
मॅडम, हे 3 दिवसाचं ज्यावेळेस आपण ट्रेनिंग घेतोय त्याचं काय आपल्याला सर्टिफिकेट वगैरे काय मिळणार का?
नाही सर, नाही मिळणार आहे सर, कारण हे जस्ट इनिशियल बेसिसवर आहे. आपण पूर्ण काही जास्त डिटेल्स मध्ये जात नाही आहोत, पण आपल्याला तेवढा वेळ नाहीये ना, तेवढ्या पिरियड मध्ये जेवढं सांगताल तेवढं आपण सांगतो, त्याचं सर्टिफिकेट नाही मिळणार सर।
ठीक आहे, ठीक।
कोणाला काही अजूनही प्रश्न